My name is Ixchel Velasco, and I'm going to talk about burosumad therapy in children with X-linked hypophosphatemia. Here I leave you my social media so you can follow me. Content: definition, application, pros and cons, issue in Ecuador, and conclusion. Definition: X-linked hypophosphatemia is characterized by increased secretion of fibroblast growth factor 23, FGF23, which leads to hypophosphatemia and consequently rickets, osteomalacia, and skeletal deformities.
X-linked hypophosphatemia is an inherited disorder of renal phosphate wasting that leads to rickets, osteomalacia, stunted growth, and ultimately lower limb deformities, pain, and physical disability. It's caused by a genetic mutation leading to excess production of fibroblast growth factor 23, which impairs renal phosphate reabsorption and vitamin D synthesis. An open-label Phase 2 study evaluated the efficacy and safety of burosumad, a recombinant human monoclonal antibody against FGF23, in children with X-linked hypophosphatemia. 52 children 5 to 12 years old with X-linked hypophosphatemia and active rickets were randomized to receive subcutaneous burosumad every 2 or every 4 weeks, titrated to achieve low normal serum phosphorus levels. Follow-up measures were assessed after 40 and 64 weeks. By week 40, the mean radiographic Thatcher-Ricketts severity score decreased from a baseline of 1.9 to 0.8 with every 2-week dosing, and from a baseline of 1.7 to 1.1 with every 4-week dosing, and the improvements persisted at week 64. Mean serum phosphorus levels increased after the first dose of burosumad. Over half of the patients attained normal levels by week 6, and the every 2-week dosing maintained stable levels through week 64. The mean standing height Z-score increased overall, patient-reported pain was reduced, and physical ability improved. Most adverse events were mild to moderate in severity. The authors conclude that for children with X-linked hypophosphatemia, burosumad improved renal phosphate reabsorption and serum phosphorus levels, reduced rickets severity and pain, and improved growth and physical function. Full study results are available at
Application: burosumad is a recombinant human IgG1 monoclonal antibody that targets FGF23-13-14 in Phase 1 and 2 trials involving adults with X-linked hypophosphatemia. Treatment with burosumad administered at a dose of up to 1 mg per kilogram of body weight every 4 weeks. Improved renal tubular phosphatase reabsorption, thereby increasing serum phosphorus to normal levels, and increased serum 1.25 dihydroxyvitamin D levels. Pros and cons. No clinical significant safety findings with burosumad were observed during the current trial. The most commonly reported adverse events were either typical for children or common manifestation of X-linked hypophosphatemia. Hyperphosphatemia was not observed in any patients during treatment. Moreover, no noteworthy change in levels of serum calcium, urinary calcium, or serum intact parathyroid hormone were noted, and no antibodies to burosumad were detected after treatment.
Hypophosphatemic rickets is a disease that always interested me. I started my training in 81, so it's now 30 years. It is not uncommon. We have about 20-25 children with this disease here at Children's Mercy Hospital between endocrinology and us, and there is excellent collaboration between the two sections. And the treatment, I would say, for the past 40 years quite standard, providing very large quantities of phosphate and vitamin D. And this treatment, if it started at an early age, is quite effective. The problem is that many patients develop side effects from these medications. So that's the main problem. So it's a very delicate balance, giving optimal dose of the medicine on one hand to achieve the therapeutic goals of correcting the rickets on one hand, while on the other making sure that the patients do not develop the side effects, the complications. And keep in mind, these side effects are being caused by us, the physicians. We are those who prescribe the medications. These side effects do not appear in untreated patients. And these side effects the two more common ones are either development of calcifications in the kidney, and you can see very clearly in ultrasound, or development of complications of the parathyroid glands, hyperparathyroidism. My goal over the year was first to convince the scientific community and also physicians that especially the complication in the parathyroid glands is due to the treatment. It took me a long time, I would say 20 years, to go to conference after conference and show my research results time and again until it became accepted. Now I think the next 6-7 years ago, a new medication appeared in the market. Again, this medication is designed or was made again for patients, mostly adults, with chronic renal failure to protect them from the complication of secondary hyperparathyroidism. But the mechanism is the same also in patients with hypophosphatemia rickets. About 3 years ago, we published the first paper, which is now very well recognized. And this was a short-term study in which we tested the kids only for 2 days, and that definitely demonstrated that the medicine has great potential in treating these patients. And since then, we have proceeded with long-term study, and the results are very encouraging.
Issue in Ecuador. In Ecuador, X-linked hypophosphatemia is among catastrophic, rare, and orphan diseases which are currently being addressed or are in the process of being progressively addressed.
Brought to you by the Endocrine Society and Hormone Health Network. X-linked hypophosphatemia, or XLH, is a rare genetic condition. It occurs when there is a genetic change in the FEX gene. This gene is responsible for regulating phosphates in the body. Phosphates provide the body with the mineral phosphorus. Phosphorus is essential for health, especially for strong bones, muscles, and teeth. The kidneys process the phosphate molecule to release phosphorus. XLH prevents the kidneys from processing phosphorus correctly, allowing too much of it to leave the body in urine. This is called phosphate wasting. Phosphate wasting leaves too little phosphorus in the body. This is known as hypophosphatemia. Hypophosphatemia leads to conditions called rickets and osteomalacia, which cause soft, weak bones. Although there can be other reasons for rickets, such as vitamin D deficiency, XLH is one of the few causes that is inherited. This means that it is passed down from parent to child on a changed gene. In about 20% of cases, though, a person develops XLH without any family history. This is because the gene changed on its own, without inheriting it from a parent. This newly changed gene, however, can potentially be passed on to the person's children. XLH has other names, including hypophosphatemic rickets, X-linked rickets, vitamin D-resistant rickets, and phosphate diabetes. Symptoms of XLH often first appear in early childhood. Because phosphorus is important for normal growth and development, children with XLH may grow slowly and not grow very tall. When they start to walk, their legs may become bowed outward or bent inward. Other symptoms can include bone and joint pain, bone fractures, problems with tooth development, anesthesia, and headaches. If an X-ray is taken, bone and joint deformities may be seen. The sooner XLH is found and treatment begun, the better. The main treatment goal is to increase the level of phosphate to allow the body to develop and function more normally. This helps ease symptoms and stop them from getting worse. Treatment generally involves taking phosphate supplements along with high-dose calcitriol, the active form of vitamin D, multiple times a day. An injectable medication taken every 2 to 4 weeks is also an option. Additional treatments help treat the disease's effects on the body. These include kidney medications, growth hormone therapy, corrective surgery, and dental procedures. In some cases, XLH symptoms are so mild they're not noticed until adulthood, but XLH may affect individuals at any age. An adult with untreated XLH may have bone and joint issues, including pain, arthritis, and fractures. Muscle pain, stiffness, and weakness are common. Hearing loss, dental, and kidney problems may also occur. Treating a lifelong condition like XLH requires a multidisciplinary approach. If you suspect that you or your child has XLH, see your healthcare provider. Getting the right diagnosis and starting treatment as soon as possible is vital to preventing problems, stopping existing problems from getting worse, and helping to provide a more comfortable, more functional life. For support information, visit xlhnetwork.org.
Conclusion. In children with X-linked hypophosphatemia, treatment with burosumad improved renal tubular phosphatate reabsorption, serum phosphorus levels, linear growth, and physical function, and reduced pain and the severity of rickets. Thank you.